Good afternoon. Happy to be here in Chicago attending ASCO 2019. Just came out from a very timely topic, and I sincerely thank NCI and ASCO to bring up this important topic to the front light, and that is to discuss health disparities. And we talked about many shades of disparities in multiple myeloma. Just to start off, when I was in medical school, average life expectancy after a diagnosis of multiple myeloma was around 2.5 to 3 years. Thankfully, recently there is major advances and the survival curve has moved up. But unfortunately, that is not true across the board. There are many shades of disparities. Racial, African Americans are known to have higher incidence, earlier onset, and more rapid progression from MGUS to multiple myeloma. But as far as the outcome is concerned, survival, we are seeing less access to novel drugs, less access to stem cell transplantation, which is supposed to be the treatment of choice for newly diagnosed transplant-eligible patients with multiple myeloma. Especially Hispanics have only 16% stem cell transplantation utilization rate in a CIBMTI report. I'm from Kansas. I take care of a lot of patients from Western Kansas, rural Kansas. The same is true there as well. We did a survey for the state of Kansas, and patients from rural zip codes, the chance of getting them referred to our cancer center and getting the novel drugs and transplantation rates are dismal. We all need to do better to improve the referral, improve access, and health delivery. The third topic was global disparity, and that is even stark, showing that the survival, whereas it's improving in North America and Europe for the last few years because of novel drugs, maintenance therapy, transplantation, actually is dropping in other parts of the world. Government health is very important in the treatment of multiple myeloma. So we had a lot of conversation afterwards. This particular topic raises more questions than answer, but that was the whole idea, that unless we know a problem exists, we would not be able to address the problem, allocate health dollars, and try to find out the answers together. It's going to be a collaboration between university centers, industry, government organizations like NCI, cooperative groups, and industry. We, as academic physicians, I personally believe, should not sit in our tower of excellence. We should go out to the grassroots, whether physically, telemedicine is something that we're doing a lot in the state of Kansas, trying to improve the recognition, trying to improve guideline-based therapy, early referral, and clinical trial access. 0 to 5% patients from rural cancers have access to clinical trial. And that's just not acceptable in 2019. We all understand that's the only way to push the envelope and improve the outcome. So I believe together we have developed a medical alliance with Midwest Cancer Network, and through that we're trying to improve upon clinical trial accrual. So again, health access delivery is so much important. And the last part is, even if there is disparity, even if there is socioeconomic imbalance, rural-urban discrepancy, when patients get the treatment, whether there's novel drug access or transplantation or clinical accrual, the outcomes are the same. So that means it is not the disease characteristics or the patient characteristics, it is the access to the healthcare. Once we get there, then we'll see uniformity of the response and the survival, and that's the dream for future. And that's probably was the main essence of this afternoon's session. Thanks for ASCO to bring up this topic.